One neuron.
Yeah, because it's just much easier to understand what that one neuron is doing versus trying to listen to multiple. And we also measure local field potential recordings, but those are analyzed, which is more of a population response, thousands of cells.
Kind of a chorus of cells.
Exactly. That we measure offline. The device that we use to sort of treat these patients or intervene that we're studying, it can't do single unit recordings. It's only doing these more population responses. So we correlate what we see in the operating room at the single unit level to the population response, but we do that all offline. And I can explain that in a moment. But yeah, so we try to identify these craving cells. And because this is a feasibility study, and we can't be in the operating room searching for hours and hours and hours, we do have we have guidelines that we've set for ourselves, that we've developed with the NIH or the FDA to make sure that what we're doing is feasible and safe as well. So we will spend a limited time trying to identify these craving cells. But another strategy that we think is really important is the effect of the stimulation. So a lot of patients, and this gets to sort of your question earlier about what comes first. A lot of people when they binge or they lose control over food or seek drugs, that moment of vulnerability is preceded by what we call a moment of sort of pre-meal negative affect, which basically means right before they binge, they're feeling down or they feel stressed or anxious. And they compensate for that momentary symptom by binging or losing control over food. Not everybody meets criteria for a binge, so I try to specify that we are looking at loss of control eating specifically, just because the criterion of a binge is not as critical for us. So what we want to be able to do is trigger stimulation when this craving is detected by the device. But we trigger it only when the craving is there. And we believe that if we can sort of temporarily elevate their mood, ever so briefly, again, this is about 5 to 10 seconds of stimulation only, that perhaps that elevation in mood could actually sort of disrupt the craving to binge cycle. Maybe that's a habit, maybe it's not. But if you crave and then you binge, if we can interrupt that with this moment of feeling good, that might be a really good therapy for a patient. And in fact, when we do deep brain stimulation for obsessive compulsive disorder, we can fairly reliably induce a positive affect. The problem is that it's not sustained. And the reason it's likely not sustained is because with obsessive compulsive disorder, we treat that condition with continuous stimulation. And it's not surprising that over time, the effect kind of goes away. So when they're in the clinic and we turn the device on, our patients feel great. And we feel like we've solved the problem. But they call us the next day and they're like, my depression came back, or my OCD hasn't gotten better and my mood's back to where it was. Can you get it back to where it was yesterday? Because that felt great.
The brain loves homeostatic regulation.
It does.
And it does not like to shift patterns.
Regression to the norm.
Right.
And I think there's sort of a tolerance effect there that is limiting the effect of continuous stimulation. And actually in a mouse, if you do continuous stimulation, the sort of blockade of binge eating goes away. So actually in a mouse, we've actually demonstrated, we published this not too long ago in PNAS, that if you deliver stimulation intermittently and only when sort of a craving signal is detected, so to speak, that effect will be the most robust and durable. But if you deliver it continuously, actually the benefit goes away over time. So I've always encouraged my colleagues to consider more of an episodic stimulation approach rather than continuous deep brain stimulation. But of course, that's for these more episodic conditions. Whereas these more quote unquote state disorders, as I oversimplified earlier, they might need more of a continuous therapy. So that's definitely subject for a lot of research in the future. So in any case, the goal in the operating room was to identify a craving cell, deliver stimulation safely, but also to capture a moment of elevated mood. We were able to do that as we are in our OCD patients as well. And also to get an intraoperative CAT scan. We have devices now in the operating room that allow us to get imaging in real time. They're fabulous tools that we didn't have 10 years ago. So we can confirm accuracy.
You can see where the electrode is
exactly.
Precisely.
Exactly. With 0.5 millimeters of error. So super precise, or as precise as we think we need to be. And we use connectomics. So there's a tool in brain imaging called tractography, where we can actually measure circuit connections. It's an indirect assay, but we believe it's powerful. It has its assumptions, but like anything in science. But we can actually map out where the nucleus accumbens connects to the prefrontal cortex, sort of the cortical control, inhibitory control pathway, and where that pathway intersects with the nucleus accumbens. And we can target that area structurally. So those three goals of the surgery we aim to set out to accomplish. And we believed if we achieved two of those three, that we would have a successful result in our early trial.
Amazing. Given that, at least to me, the non-clinician, that anorexia is the mirror image of binge eating disorder, and at least from what I learned, one of the more deadly psychiatric conditions, but also quite common.
Yes.
Is it possible that nucleus accumbens, this so-called reward circuit, is also involved in anorexia, but somehow it is the resistance to eating, the craving of the fasted state, or something like that that's being reinforced?
Yeah.
And I ask this for two reasons. One, because I'm genuinely curious about anorexia. I've observed anorexia in a number of people that I know, and it's a striking thing to see somebody just resist food despite all better knowledge of the fact that they're getting quite ill, and maybe even at risk of death. But the other reason is that if in fact nucleus accumbens is the site which can harbor cells to promote craving and craving of fasted states, so to speak, then that I think might tell us something fundamental about how the brain works, which is that structures don't control functions per se. Structures control dynamics of interactions. Sort of like a orchestra conductor has a certain number of operations that they perform, but really their main function is to coordinate the actions of a lot of things, not to make sure that the violins always play in a certain way alongside the oboes. You can tell I'm not a musician here.
At least you have an appreciation for the oboes. Those usually get left out.
What's that, the oboes?
Yeah, they usually get ignored.
My partner plays the oboe.
Oh, wow.
Yeah. I
think it's a great analogy, by the way. I make this statement. It's a little controversial, but I actually think people would understand where I'm coming from across all of these sort of subspecialties of medicine. But I actually think, especially with obesity, remember it's a phenotype that's reflective, often but not always, of a behavior. But if you consider patients that have obesity and they exhibit some sort of compulsion towards food, so they overeat despite the risk of it, I think those kinds of patients are more similar to anorexics than they are different. Anorexia and obesity are both phenotypes that are, at least in this specific case of obesity and in anorexia, a result of a compulsion to either over or undereat despite the risk. These types of compulsions are driven by societal pressures, brain vulnerabilities that are probably more similar than they are different. They just happen to manifest differently. Why they manifest differently is probably related to each patient's predisposition or perhaps preference. That's hard to know. Like you, I have a personal connection to these eating disorders, anorexia included, and I think it's very scary. And it's a condition that often instills fear in psychiatrists because I think, not everybody, by the way. I mean, I have some phenomenal psychiatrists that I work with both at Stanford and at Penn. They're also involved in my obesity study that take care of these patients. I mean, these are heroes, but there's a lot of psychiatrists that are not in this domain that find anorexia scary for the reason you said. It has the highest mortality of all psychiatric conditions. That includes depression. because not only can these patients die of suicide, but they die of metabolic complications of being underweight. So it is a scary condition. I relate with that. I am trying over time to bridge what I'm doing in obesity and binging disorder to anorexia for two reasons. One, because I think these problems are more similar than they are different. And two, because of the need. And I think we're well positioned to sort of tackle anorexia using similar approaches, not identical, but similar approaches. The nucleus accumbens has been studied in patients with anorexia in China. Actually, my first postdoc, who I had the honor to train when I was at Stanford, is a neurosurgeon in China. Before he came to me, actually was involved in a trial of anorexia that had some benefits. And there's studies in Europe and elsewhere that have examined preliminarily the effects of deep brain stimulation targeting the nucleus accumbens for anorexia. Colleagues of mine in Canada, Andres Lozado is a wonderful neurosurgeon scientist, has been studying the effects of going after area 25, which is directly connected to the nucleus accumbens by it's a monosynaptic connection. So in a lot of ways, perhaps delivering stimulation there could be very similar to delivering stimulation to the nucleus accumbens. It's all part of one critical inhibitory control circuit. He's seen benefits as well. So I definitely think there's some evidence that this is an area that we need to be studying. I think our more episodic approach with responsive stimulation, going after sort of a signal in the nucleus accumbens that seems to be related to the compulsion to withhold from eating, I think is what we will be trying to accomplish in our study. It's right now just being conceived, though. These studies, they move so slowly because you have to get a grant. That grant gets reviewed by the NIH 6 months after you submit it, often gets rejected because it's too innovative and too high risk. So then you have to edit it and decrease the risk. So my obesity study took 2 years to get funded. And I worry about that time frame because that's a lot of time for patients with anorexia to suffer that I might be able to help, at least in a small sample of patients. So, but that is the nature of how these things go. You also have to get FDA approval to do these kinds of things. We try to do all of this in parallel. It's an enormous undertaking. And in a lot of ways, we're starting from scratch, but in some ways, we have some preliminary data to go after this. So my hope is in about a year, we'll have a similar trial for anorexia at Penn. So more to come on that. And we're not the only lab that's trying to go after it because of the clear need. So,
what is the status of non-invasive brain stimulation, ablation, and blocking activity in the brain? I get a lot of questions about transcranial magnetic stimulation.
Yeah.
I've actually had that done as a research subject.
Sure.
When I was at Berkeley, Rich Ivory's lab put a coil on my head. I was tapping my finger in concert to a drum beat. And then all of a sudden, because of the stimulation, it was impossible for me to keep time with the drum beat.
That's cool.
It's a pretty wild experience to not have motor control and then to have motor control returned at the flip of a switch when someone else is controlling the switch makes it especially eerie. So my understanding is that transcranial magnetic stimulation is being used to treat depression and a number of other brain syndromes non-invasively, so no drilling through the skull. The surgeons don't like that. Surgeons love to cut and drill with purpose, but they do.
With purpose, yes.
But my understanding is that the spatial precision isn't that great.
Yes.
Ultrasound is something I hear a lot about these days. And my understanding is that ultrasound can allow researchers and clinicians to stimulate specific brain areas, perhaps with more precision. Mm-hmm. Maybe you could just give us a brief coverage of what those are being used for. What are your thoughts on these forms of non-invasive, meaning no flipping open of a piece of the skull type brain stimulation and blockade of brain activity?
Sure. Yeah, I wanted to clarify also, these surgeries generally don't, by the way, require a full craniotomy. It's usually just a small opening about the size of a dime in the bone. So just to clarify. But that
painless too, right?
Well, usually without pain.
Yeah, a little bit of scalp numbing.
We give a scalp block and the patients are getting IV sedation. So they, in general, don't feel anything. And if they do, they tell me and we give them more local anesthetic. But they're usually asleep during that part. So it's minimally invasive. But in a lot of ways, there's no such thing as a minimally invasive procedure in the brain. It's kind
I'm
of a
so glad
misnomer.
to hear you say that.
Oh no, I am not one of those neurosurgeons that you've probably encountered, and we have mutual friends that, and these mutual friends are some of my favorite people in neurosurgery, and they probably actually think more like me than not. But there are neurosurgeons that you're absolutely right, and this is true for all surgeries. They really, in a lot of ways, they think what they do is sort of the ground truth, or is closer to the ground truth, and I get that. Probing with purpose. I actually really like that. I'm going to use that if you don't mind.
It's just describing what you do. Yeah. So
But I actually have always said this. I've said it publicly. I've said it to my boss. I've said this to my team. We need to embrace non-invasive approaches. Some of them are a little fluffy. Fluffy in that we don't understand how they work. We don't necessarily understand how deep brain stimulation works, by the way. So. But because we don't know exactly how they work, they're not as precise as we would like them to be. So we have work to do there. And I actually think that work is doable and actually underway. At Stanford, we have great collaborators that I think are doing this, people like Nolan Williams and Connor Liston at Cornell and others. I think that TMS, transcranial magnetic stimulation, it is FDA approved for depression. By the way, it's also FDA approved for OCD and for nicotine addiction.
Where do they put the coil for those three things, or more or less?
Yeah, so they put it over, it's always on the scalp and over the frontal lobe. And there's different parts of the frontal lobe that have been demonstrated to be a little better or a little bit worse. But what the FDA has approved for depression, I believe, is similar to what's been approved for OCD. But for addiction, I believe it is a different target. But we'd have to ask our TMS experts on that.
Can they direct the transcranial magnetic stimulation deep below the cortex?
They try. And we're actually studying this in OCD patients now. As a part of our invasive trial, we are trying to pool patients from a TMS trial that's in parallel to what we're doing. All funded by the Foundation for OCD Research, where we believe we can use TMS to define a circuit that, if modulated, improves OCD, albeit temporarily. And in those patients, if it's temporary, they would be appropriate for an invasive study. So something we're actively working on. I've always believed that neurosurgeons need to be part of the discussion with these non-invasive approaches. We don't need to do them. But I think we can help make them more precise and to probe non-invasively with purpose, rather than this more kind of, a non-invasive blast effect kind of, I just can't imagine how that is going to be as effective as probing with purpose. But you can do that non-invasively as well. And I think we need to do better in that way. I do believe that's possible, and I think people are actively trying to do it. Getting deep in the brain with TMS, I think, will always be hard, but you can get there indirectly by using connectivity assays and targeting superficial structures that have high connectivity to deep structures. So, for example, perhaps one day there will be a TMS target for anorexia and obesity. If we are scratching the surface with invasive approaches to these problems, we're even doing less with the brain stimulation. So we have so much work to do there. Eating disorders and TMS have been so scarcely studied, or there have been such little research done in that space. So it is an area that we need to work on. For the obvious reason, for example, in a patient with anorexia, just thinking practically, placing a device in a patient who is significantly underweight might not be the best approach. Wound erosion and issues like that could come up. So developing a non-invasive approach, I think, is critical. The problem is, where do we target? And so the only way to answer that, I think, reliably is to accept that we have to get into the brain before we're out of the brain. And with these kinds of conditions, we're only just starting to get into the brain, So I worry that we're a long way away from a non-invasive approach that really works consistently.
Sorry to interrupt,
yeah.
but I want to make sure we touch on ultrasound.
Yes, sure. No, I love that.
Historically, it seemed that there was a bit more permission for people to probe around in the human brain. I've sometimes refer on the podcast to some of these papers that were done allowing patients to self-stimulate in the brain. These are work done in the 60s, and now his name escapes me. Robert. Anyway, there's a couple of papers published in Science allowing patients to stimulate a couple different brain areas, asking which ones they preferred. And I was always shocked and slightly intrigued by the fact that the brain area that all three of these patients, who I don't think had any syndromes, I think they volunteered for these experiments. I don't think you could do this anymore.
Yes. Regulatory
things have changed.
Was not the same as it is now.
Things have changed, fortunately. But they, all three of them seem to like some midline thalamic structure, which for those listening is just an area kind of in the dead center of the brain, more or less, that evoked a sense of kind of frustration and anger, which surprised me because I would have thought, it's Robert Heath. These experiments, rather than patients preferring to stimulate areas that evoke laughter or joy or a feeling of drunkenness or delight. It also explains a lot of what I observe in social media, this sort of kind of people repeatedly engaging in battles that are kind of trivial. It seems like frustration and anger might have its own reward circuitry. Mm-hmm. Anyway, I don't want to go too far down that rabbit hole, but it's
a deep one.
It's a deep one, and kind of gets to our nature. As humans and what we find interesting or rewarding. But, the inability to probe around the brain in a safe way without the need for somebody to be very sick would be enormously powerful. And at least to my mind, if I were in charge, which I'm not, would offer the opportunity to really come to an understanding about how the human brain works without all these issues of how to translate from mouse studies. And again, there's huge value to animal studies, as we both agree, but so many of the things that we want to know about the human brain involve asking the person, hey, what do you feel when that set of neurons is stimulated? And what don't you feel? Yep. And a mouse, we can ask and ask, but they're not going to tell us, and they do tell us, they're not going to tell us in English. So how do we overcome this challenge? But first, ultrasound, or if you prefer after ultrasound, what is ultrasound going to be really useful towards solving these clinical issues and these basic issues?
Yeah, so I think let's start with ultrasound, then we'll come back to it. So ultrasound right now, transcranial magnetic resonance guided focus ultrasound. So this is an FDA-approved method to deliver an ablation to the brain non-invasively. There are researchers, myself included, that are trying to use transcranial magnetic resonance guided focus ultrasound, or MRI guided focus ultrasound, to use it in a modulatory way, not just as an ablation, but to drive neuronal activity or inhibit it, perhaps. We're still learning how to do that. There are trials that are trying to understand if you can use ultrasound to open the blood-brain barrier so you can deliver a medication to that specific area, perhaps for a brain tumor or something like that. So it's a very exciting field. And it is FDA approved for tremor right now. And so I actually do it routinely for patients with tremor, with Parkinson's or essential tremor. And so I love doing it. It's often just kind of a miracle because there's no incision. I don't have to place an electrode into the brain to achieve a similar result.
How early into the pathology of Parkinson's can someone think about approaching this? So for instance, if somebody has a parent or a sibling and they're developing some resting tremor, obviously they should talk to a neurologist, but a neurosurgeon, but this non-invasive approach could be incredible for them, as opposed to just only taking drugs to increase dopamine levels.
Yeah, so depending on the reason you have tremor would dictate the kind of medication you would use. It could be Parkinson's, but if it's not, it might be essential tremor. By the way, essential tremor is 10 times as common as Parkinson's.
Really?
Essential tremor is the most common neurologic condition in patients over the age of 70. We often aren't aware of that. People with essential tremor feel they have their forgotten disease because there's no Michael J. Fox for essential tremor. I sent a letter to Bill.
Is it essential tremor or
essential tremor?
Yep,
ESSENTIAL. I actually sent a letter to Bill Clinton. I've observed tremor in him, and I think he's actually disclosed that he has it, and I've hoped he'd become a champion for patients with essential tremor. Sandra Day O'Connor does as well. She's also public about it, but I was not able to get them eager to become the champion for this condition. But like Michael J. Fox, these patients need a champion like that. But unfortunately, it's a bit of a forgotten disease. Now, Nevertheless, because of the FDA approval of focus ultrasound for tremor, they're trying to get some attention for sure. And it's fabulously effective for these patients. It treats patients on one side, usually their dominant hand or their worse hand. And it really speaks to the fact that, wow, you can deliver non-invasively an ablation to the brain in a hypothesized zone that we think is related to the problem at hand. And at least with tremor, it works really well. Could this be effective for psychiatric disease, obesity, eating disorders? Perhaps. Actually, that would be the ideal. The problem is we don't know where to do the ablation. There is a trial that we would like to do for OCD where we would deliver an ablation to the same area of the brain that we've been delivering ablations to for years for patients with OCD, and it helps a bit. That's called a capsulotomy. But really, the outcome is probably going to be about the same. It's a nice method because it's non-invasive, but we need to find a new target for these conditions. And because of the common denominator of the urge despite the risk, sort of that compulsion, perhaps it could be the same target. I don't know. But I would argue we need to do these modulatory experiments either with a device or with invasive recordings to better understand where these problems are coming from, to define where we should do an ultrasound treatment. So you're right. Historically, without much regulation, we've probed the brain. The problem, we can't learn a lot from those experiments now. In this way at least. We don't know exactly where those electrodes were. We didn't have MRI scanning or high-quality CAT scanning to know where those electrodes were with certainty. And we know 2 or 3 millimeters matters. And we also didn't have the tools to place electrodes in a precise way back then. So unfortunately, we can't learn a lot from those experiments right now. So we're sort of redesigning them. And there is a way to do it now. Patients with epilepsy benefit from this all the time. There has been a revolution in America. It was in Europe before it was in America, where we would do stereoencephalography, which is basically like doing an EEG of patients with epilepsy, but with invasive electrodes. And we would place tiny little wires, less than a millimeter in diameter, all throughout the brain into parts of the brain that we believe are involved in seizures. And we would admit the patients to the hospital and figure out where the seizures were starting and propagating. And then, we could stimulate those electrodes to see if there was a symptom that was important and try to identify a region that we thought we could either remove surgically, ablate with a laser, or put a stimulator in it, perhaps. That's commonplace now for epilepsy. And it works extremely well, and it's very safe. Of course, it's still a brain procedure, but the complication rate is surprisingly low, quite honestly, for the amount of electrodes that we place. And it's extremely well tolerated. Most of these patients leave the hospital and they don't even feel like they've had surgery. So there's actually a lot of interest in using that procedure to study mental health disorders. We are trying to do it for patients with obsessive compulsive disorder. We're awaiting an FDA decision on that. But actually, I credit our colleagues at Baylor and at UCSF for studying this already. We have fabulous colleagues at UCSF that have studied depression using this type of approach. A mutual friend of ours, Eddie Chang, who's a wonderful friend and colleague, somebody I've emulated for many years as well. And the psychiatry team at UCSF have worked together on this, sort of bringing together the epilepsy technique and the psychiatry expertise to study how we could better target electrodes in depression. And I'll tell you, if they have a consistent target, perhaps there becomes an ultrasound target. But right now, the approach is a bit more reversible because you can always shut that electrode off or even remove the electrode if perhaps it's not in the optimal location to treat the depression. But actually, after a large volume of cases, perhaps they could pool that data to develop a new ultrasound target for depression. I think that would be fabulous and probably is their long-term goal. Not to speak for them, but that would be something that I'm sure is on their radar. And Baylor is trying to do the same thing for depression. Their approaches are a little bit different, but a similar tool to try to understand depression. And we're working with all of these types of colleagues. Some of these are our friends to try to bring this to OCD as well. And it makes sense to try to do this for addiction and obesity and anorexia. You might ask, well, why aren't you doing this for obesity right now in our study? And the reason is that we've developed a target for obesity and binge eating disorder developed out of mice that we believe is relevant for the human state, because you can model this problem in a mouse a bit better than you can model depression or OCD. So we feel like we can rely on the preclinical studies more. Whereas with these perhaps more, I don't want to say more complicated, but more human mental health conditions that are hard to model in a mouse, you really have to study it in the human. And you can perhaps start in an epileptic patient, a patient that has electrodes, and try to provoke a depressed state, or study epileptics like Dr. Chang has done that have comorbid depression, for example. And that can really validate this approach as well. But in the end, it's getting into the human brain that we need to do in the disease specifically, that will eventually lead to a non-invasive approach, either a lesion or modulatory approach. Modulatory would be like TMS, or lesion approach would be with ultrasound.
I couldn't agree more. Meanwhile, because there are many, many millions of people suffering from depression, eating disorders, Parkinson's, and essential tremor, et cetera. Well, first of all, I should say, based on everything you've told me thus far, it's amazing to me that any pharmacologic treatments work because of how systemic they are and impacting serotonergic neurons over here and dopaminergic neurons over there, and not targeting any specific batch of cells. It makes perfect sense as to why all the side effects exist. But earlier you said something that really grabbed my attention I want to come back to, which is that if people can be made to feel, or make themselves feel, just a little bit better, a little less anxious just prior to a craving episode or a binge episode, maybe even if people can become better at detecting their own internal states, and when they're kind of veering toward a binge, or veering toward using a drug, or maybe even veering towards suicidal thinking. Based on what you said earlier, that those kind of pre-behavioral states, the kind of drift on the steering, those sound like powerful levels of awareness, at least for now, until we have specific sites in the brain that we can target, non-invasive methods that could be deployed to millions and millions of people. Seems like that awareness seems like maybe among the best tools that people could develop.
Yes, I 100% agree with you.
You know, so for the person with OCD or who suffers from anorexia or binge eating disorder, and to their clinicians, you know, I just want to highlight that you said that. I mean, I'm not a clinician. I always say this. I don't prescribe anything. I profess things. But awareness of one's thinking seems immensely powerful in this context.
Yeah.
And after all, it is the clinical probe that you use, because if let's say the patient were to lie to you about their experience of what happens in their mind when you stimulate, you could basically the whole thing, the whole surgery, the whole procedure could go badly wrong. Mm-hmm. So it's up to the patient to be, of course, honest with you, and they're incentivized to do that, but to be honest with themselves about, I've gone all day without a binge, but the smell of a donut or the thought of a donut is starting to have a particular allure. That awareness seems like an incredibly powerful thing to own and to build and cultivate.
Yes. I've always thought that if we can improve awareness, we can improve outcomes. I think that's probably true for many of these patients. The problem, I think, comes down to the fact that some of these patients are so resistant to treatment. And the patients that we see as a surgeon, for example, are the patients that they've tried cognitive behavioral therapy, certainly have tried medications, they've tried behavioral management. They are aware of their problem, and they've shown that to us. They can tell us when they're craving, but despite the craving and despite being involved in this invasive brain surgical trial, highly, first in human novel study, which I think will have a positive effect, but it's still experimental. They still can't stop themselves. So they're sort of as made aware as could possibly be. Did I use grammar there correctly? I think so. They're as aware as they could possibly be, and they still lose control. We've had this studied in the lab. So we will bring patients to the laboratory with this implanted device to try to provoke this electrical signal that can be detected by the actual device that will stimulate them when they're at home. But before we actually initiate stimulation, we want to see, can this device detect this craving cell signal, which is going to be different than what we saw in the operating room because that's a single cell. But these devices, these electrodes are about 1 millimeter in diameter instead of like 1/10 of a millimeter, which is what we use in the operating room. So they're only hearing or detecting, I should say, thousands of cells responses. And we actually have a way to provoke binges. It's called a mood provocation. It's very well validated. It's a little bit like provoking seizures in the epilepsy monitoring unit, but here in the sort of psychiatric monitoring unit or the food monitoring unit, we actually have a psychiatrist and eating disorder specialist come and induce a mood that is related to each patient's sort of self-described binge episode.
So the psychiatrist comes in and provokes
Yes.
a feeling that can evoke the negative behavior.
That's exactly right. So that we can video and synchronize the video to the brain signal recordings. The patients all wear an eye tracker so we can see what they're eating at all times and what they're looking at specifically. And that allows us to have the best temporal resolution possible to understand what is happening right before the bite. And even under video surveillance through a one-way mirror in a laboratory setting, when patients are very well aware that they're there to be studied if they're going to binge, they still do. And we believe they do because they just can't control it, as aware as they are of it. And it's probably because they're the most severe. So I think if we can improve awareness, not just the societal awareness that I was talking about earlier, but the patient awareness around their problem, I think that could be a powerful way to help so many of these patients. And that's sort of the role of cognitive behavioral therapy. The problem with cognitive behavioral therapy, or I should say the limitation of it, I actually don't have any problem with it. I think it's a wonderful treatment, is that if you stop it, many of these patients go back to their old behaviors. I don't want to say old habits, but it might be a habit, but the old behaviors. And so that's the problem, is that it's not necessarily lasting in the absence of continued cognitive behavioral therapy. Some people can benefit from it long-term, but some can't. But I think in the less severe patients, improving awareness, key. But in these really refractory patients, this is kind of like, this is the disease. Despite the awareness, they can't control themselves. And that's what we're trying to restore, is that improved ability to control their behavior.
Do you think there's a role for machines and artificial intelligence here? There are a couple laboratories up at the University of Washington that are using particular signature patterns within voice to try and help people who are suicidally depressed know when they're headed towards an episode before they even can consciously know. So this gets right down to issues of free will and whether or not machines can be smarter than we are. But one could argue that some of the search algorithms on Google and other search engines are actually more aware of our preferences than we are. Mm-hmm. Basically what these are devices that are listening to people talk all day. They're also paying attention to patterns of breathing and how well people slept, et cetera, integrating a huge number of cues and then signaling somebody with a yellow light. Like, you're headed into a depressive episode and the person might say, oh, I feel fine, or I feel pretty good. This is kind of baseline state for me. And they say, this is where you were preceding the last episode that took you down a deep, dark trench and it took months to get out of. Yep. I wonder whether or not some of these devices could help with the sorts of things that we're talking about today.
Yeah, I think so. I've always said we have to get in the brain before we get out of it. And if we get in the brain and understand what these signals look like, we'll know what those non-invasive signals are. I think it's possible that we are scientifically sophisticated enough to use machine learning and sort of this kind of bot technique to anticipate when somebody is going to be highly impulsive. Suicide is the most dangerous impulse. It's something that is immensely a focus of the lab, is impulsivity. We've talked mostly about compulsion. Compulsion being, going after a reward or the urge despite the risk. Impulsivity is similar but different. It's kind of going after something a little bit. If you model impulsivity in a mouse, it's related to going after a food reward without the sort of paired tone that the mouse is supposed to wait for. The mouse doesn't want to wait anymore. They just go after the food.
I've been that mouse.
Yeah, we all have been. We can all relate with this to a certain extent. Again, it's a spectrum.
Mm-hmm.
So in any case, non sequitur, but I certainly think that there is a way to use our own body's physiology to anticipate when these impulses are coming online. How best to do that, I think we're just scratching the surface, but these are the kinds of solutions we need. Some of these problems are of epidemic proportions, the largest public health problems in this country, in this world: obesity, opiate crisis, depression, suicidality. I mean, that's like a third of our country, maybe more, probably more. And think about it.
And a colleague of ours at Stanford Psychiatry told me something that still just blows my mind, which is that something like 75% of the antidepressant and anti-anxiety medication that exists in the world is consumed in the United States.
It's amazing.
Which is, that's an outrageous number.
Yeah, we do have an obsession in this country for pharmacy, and the pharmaceutical industry is very powerful here and probably related to some aspect of capitalism. I'm capitalistic and just like everybody else, but I do worry about that a little bit. But we tend to overprescribe, and I think we as patients tend to overwant medication. We like quick solutions, and sometimes medications provide it, sometimes not, or they're often just a Band-Aid. Depends on the problem, of course. But I agree that we need scalable solutions. But I'm a neurosurgeon. I'm only going to be able to treat the most severe of patients with these problems. We've only done about 200,000 deep brain stimulation surgeries ever. So, the problem we're talking about here is 50 million Americans. There's no possibility that surgeons can address that problem, but we could help inspire an initiative to go after that kind of problem, or help make it more rigorous. Because the last thing we need is some sort of wearable fancy tool that, wastes people's money and time. We need real therapies for these things. Not that these devices that we're discussing are not. I think actually there's lots of promise. And we use machine learning in the lab all the time. I'm not an electrical engineer or the computational neuroscientist doing this type of work. I just help develop the hypotheses around it, but and help fundraise around it. But I definitely think there's a future for it. I suspect we're scratching the surface on how best to do it.
Let's talk about your hands.
Yeah, sure.
All the neurosurgeons I know are, very faithfully protect their hands. And
it's because hand insurance is too expensive.
That's right. But I'm guessing that you all are not the ones to reach into the garbage disposal, even if your eye is on the switch to make sure that it isn't going to get turned on. They're just too precious. They are your livelihood.
Yeah.
And earlier we talked about deadlifts. There are other forms of exercise. There are things like tennis. There's drawing and painting, a full range of things that one can do with their hands. Use your imagination, folks.
Sure.
Is it true that neurosurgeons don't do any really like heavy grip activity because it can refine the motor circuits in the brain and elsewhere that can throw off their neurosurgery game?
I would say that many neurosurgeons avoid activities that put their hands at risk. Another one, by the way, there's an annual softball tournament that neurosurgeons come to in New York City in Central Park
with a very soft ball. No, I'm just kidding.
Well, actually, it's actually a very typical hard softball. I don't know why they call it softball. And actually, two close colleagues of mine have gotten injured at that tournament.
Maybe this is it's also, I must say, and here I'm poking fun, but for those of you who are going to the medical profession, it's also one of the more, how should I say this? Well, I'm just going to say it. There's a steep hierarchy of training in neurosurgery.
Yes.
There's a certain harshness that's been conveyed to me about the training, much like astronaut training, to be totally fair. And so maybe this is a tactic to to weed out either the younger or the older generation.
This is evolution, right? We have to evolve and
Darwinian medical
weed out the
training.
weak, I guess. Well, I could say that one of the individuals that got injured is one of the more senior surgeons that I work with now, and is one of the best athletes that I know, and he's definitely not weak. But you can get injured playing these sports. And that being said, I can tell you briefly is I think that, it's funny. My mother came to me recently. She has osteopenia, and she told me her doctor told her she's not allowed to do deadlifts. And I was like, okay, that's fine. I'm not telling you should do deadlifts. I just don't exactly understand the relationship. But I can say that I do think, I'll give you a little story here. The reason why I'm being a little hesitant to confirm that I agree with you on the deadlifts is when I was operating, this was when I was at Stanford University operating, and we, as I mentioned earlier, we get an intraoperative CAT scan to confirm accuracy of our electrodes. I do this for all of my surgeries. When I was reviewing that CAT scan, the X-ray technician looked at me and whispered into my ear, he's like, "Your posture is really bad. It's embarrassing."
Your physical posture
My
while
posture.
doing your surgeries.
Yeah.
Uh-huh.
And I looked at him, and I kind of wanted to say I won't curse, but yeah, exactly. I mean, I've been doing it intermittently during our conversation, because he made me realize that I really did have bad posture. And we kind of had a little brief aside, and I learned he was a personal trainer, and his name was Zach. And he said to me, your posture is weak or your posture is poor because you're weak. You need to strengthen your body and strengthen your core. I was like, how? He's like, powerlifting. And I'm like, I'm a little hesitant to do this. And I'll tell you, I started very slowly. And I can't prescribe powerlifting to everybody for the exact reason you said. And I've gotten hurt doing it, by the way. But I do think, I wish I started a little younger. And I would argue that with close supervision and very well, if you have a very experienced trainer, which I would argue if you're a neurosurgeon or an astronaut, or have a highly specialized profession where you need your limbs to function, dentists, things like that. If you're going to take something on like this, it really needs to be extremely carefully supervised. And I can tell you that, my trainer had a profound impact on my life and my posture and my physical health. And so we did deadlift, I'll admit. So when you brought it up, I kind of chuckled to myself. But yes, I have gotten mildly hurt deadlifting, but it was when I was doing it by myself and I was kind of cocky and I wasn't paying attention. But when I was with him and he was all over my technique, it actually was the most efficient way for me to feel stronger, and it improved my posture significantly. And I miss him since I left California. I have a new trainer in Philadelphia who's great, but and I still deadlift occasionally with him. But I can say I am opposed to deadlifting callously. But if you're extremely well monitored by an experienced personal trainer or weightlifter, I think it actually could be a great exercise.
Great. I love to be wrong in this case because I'm a huge proponent, and on the podcast I go on and on. I mean, there's so much data now pointing to the fact that 180 to 200 minutes of zone 2 cardio, kind of jogging, cycling, swimming type behavior is very healthy for everybody. And we should all be doing that, at least that.
Yes, I need to as well.
And that resistance training on the order of, 6 hard sets per muscle group per week is really important just to offset deterioration of muscles. And
I'm learning as we go here.
Skeletal function and tendon strength. And that's just to maintain. We're not talking about all out sets to absolute failure, but as you point out with proper form. So yes. Even the neurosurgeons are doing this, which I think is wonderful.
Yes.
As a final question, but one that I think really, or maybe second to final question, earlier I commented on the remarkable calm, at least perceived calm, of neurosurgeons. It could be cause or could be effect of the training. But it's obvious to me why one would want that trait in their neurosurgeon. I wouldn't want a hyperactive, certainly not an impulsive neurosurgeon, given that the margins of error are so tiny on the spatial scale and probably on the temporal scale too.
Yes.
You don't want people doing things in time that are, or being spontaneous at all. Do you think that this branch of medicine that you're in selects for people that at least can know how to control any kind of fluctuations in autonomic arousal? They can calm themselves in real time. And here's a specific question. When I've never operated on the human brain, although I've had the privilege of being in the operating room and seeing this with some of our experiments with people in VR. It's a remarkable thing. I wish for everybody they would get this experience at some point, not hopefully as a patient unless they have a need, but to observe it. But what was just striking to me is the various stereotype behaviors of the surgeon. And when I did surgeries as a graduate student, as a postdoc in the brains of other types of animals, I would find, for instance, that if I started to tremble a little bit, if I tapped my left foot, that my hand would stabilize a bit, that there's this kind of need to move the body, or one feels the impulse. Maybe that's my Tourette's-like compulsions again. But that one can kind of siphon off some of that energy into another limb so that you could remain precise. So are these sorts of things that I'm talking about, maybe it's entirely my imagination, but are these the sorts of things that one learns as a neurosurgeon, how to still the body and still the mind? Do you have a meditative practice? When you go into the operating room, if you had a particularly challenging morning or a poor night's sleep, do you have tools that you use to calibrate yourself and get yourself into the zone? I think this would be very interesting for people to get some insight into, even if they don't want to be a neurosurgeon.
Yeah, I completely agree. And I appreciate the earlier reference to neurosurgeons as astronauts, because I've also heard, us compared to cowboys before, and it's a little bit less flattering. Some of what we do surgically really does require a substantial amount of confidence. And that confidence hopefully comes from years of training and experience. You always worry that the confidence is sort of misplaced, and that is problematic. Luckily, we so rarely see that because our training is so rigorous. We have a board of American Board of Neurological Surgeons that sort of allows and assesses surgeons to continue practice and holds us to a really high bar. I do think it tends to attract a certain personality. In my subspecialty, as a deep brain stimulation surgeon, we call it stereotactic and functional neurosurgery. Some people have likened us to the neurologists with a scalpel. We tend to be a bit more intellectual, maybe bedside manner is a little bit friendlier. And then there's the vascular neurosurgeon who doesn't sleep, and so they're not as friendly. There's the spine surgeons who operate the most, and so they're busy. There are some of these kind of reputations going around, but I agree with you. There's a sort of a common feature of a calmness across neurosurgeons, and there's some of my favorite people, my closest friends, and I can relate with them probably because of that. Sort of a big picture. They don't get sort of flustered. They tend to be really good at figuring out how to have quality time because we work really hard. Our hours are significant. And so the time with our families, our friends, is less than we would like it to be. Obviously, that's true for people who work hard across any profession, but definitely true for neurosurgeons. And I think that we're very good at figuring out how to make that time high quality. Even just texting with some of my friends that are neurosurgeons. A great friend of mine just became chairman at Duke, and just connecting with him by text, which takes seconds, we feel connected, and I think that's a trait amongst neurosurgeons. We sort of know how to cut to the chase in a way, and prioritize our time. It's a skill that we probably have innately, but is also part of the training. When we are interns now, there's a lot of work hour regulations that is probably quite appropriate, by the way. I think our hours before were bordering on not necessarily, let's just say they were not ideal for mental health and sleep, which we know are very important components. Certainly we had no time for meditation. I definitely did not. I wish I did. Now, knowing what I know about meditation, my wife's a health coach. I get it. I see it. I practice it myself with her. I see the value. I wish I had that tool when I was in training because it's stressful. Even with the work hour restrictions, we still don't sleep very much. We're still at work a lot, about 80 hours, a week.
Throughout the entire career?
There are times when it's more because after training, there's no work hour restrictions. So sometimes I feel like as faculty, we get abused and the trainees are a little bit more protected now. Definitely was the reverse at one point. And that's also a huge problem, probably more of a problem. And I'm joking a little bit. I don't necessarily think we're abused, but certainly our hours are significant. But, they come a bit more here and there. On my OR days when I'm operating, those are long days. But on the days that I'm lucky enough to be a researcher, like you, those days tend to be a bit gentler unless I'm grant writing. Those days can be long, as you know. So to answer your question, I do think we're sort of self-selected for it, but I also think it's part of the training. Because of the long hours that we're in the hospital, we're taking care of sick patients. And we have sort of a type A mentor approach where our mentors are hard on us. We learn to cope with our stress and be efficient and prioritize things despite the stress of it all. And I think, we take from that this sort of calm demeanor. And, perhaps it just amplifies what we're probably drawn to, because before we come to neurosurgery, we might rotate in neurosurgery. We might spend a month pretending to be a neurosurgeon, learning from residents and faculty that are practicing the specialty. But, prior to actually starting your training, you never experience anything like being a resident in neurosurgery. The stress and the volume of patients that you have to take care of and the long nights. It can be quite lonely, by the way. You develop friends in the hospital, but sometimes you're on your own when you're on call, and you have backup. You can call your chief resident or your attending, but you really have to learn how to take care of patients yourself. You obviously form teams with nurses and staff and things like that and other residents, but it can be lonely. It can be really challenging. And I think because of those experiences that all neurosurgeons go through, we tend to have this sort of unflappable personality that perhaps we started with a bit compared to the average person, but the training definitely amplifies it.
And do you have tools that you implement if you ever feel that you're getting slightly off center?
I do now. When I was in training, I actually remember in my second year. So most neurosurgery programs, when you're a junior resident, in some ways that's your toughest year. Not in every way. It is your toughest year because you're young and you're inexperienced and you don't know what you don't know. And that's why it's such a tough year, because you have to learn a lot very quickly for patient safety reasons, for self-survival. You just have to learn a lot. And you're on call by yourself in the hospital, and it's a real challenge. And I think that, personally, I gained a lot of weight during that year. The only exercise I did consciously was taking the stairs. I refused to take the elevator. And I was at Penn, at HUP, where I currently practice now. And I remember I would see patients anywhere from sort of the ground floor where the trauma bay was, or the ER, all the way up to Founders 12, the 12th floor. And I would never take an elevator. That was my rule for the year, because I knew I would not have time to exercise, but I would just take the stairs. And in the beginning of the year, I would be a little winded when I got to the 12th floor. But by the end of the year, actually, it didn't really faze me, and it became a great habit to have. The problem with that, though, is I paired that, unfortunately, with a lot of sleepless nights, or not enough sleep, let's say. And I had this terrible habit of drinking coffee late at night, and I would put a lot of sugar in it. And it was sort of the only way for me to get a quick, a quick bout of energy that for some reason I prioritized at that time, obviously knowing that I would crash, which I always did, and I always kind of regretted it, but I still did it anyway. And I attribute that to poor decision-making, inexperience, and perhaps being a little vulnerable, like I think we all are. That's why I relate with a lot of the research that I do. And I remember I got married in my third year, the year after my second year. And my wife and I, or my fiance at the time, we started going to the gym together in the morning, and my hours were a little better, so I would actually be able to exercise before I operated that day. And I operated almost every day as a third-year resident. So I remember I'd get to the gym really early, and in 3 months, I lost like 20 pounds. And I wasn't trying to lose weight. I just was sleeping better and taking care of myself. And I remember when we got married, I fit into a tuxedo that I had in college, or it would have fit me in college. It actually was a new tuxedo, admittedly, but it was the same size as my tuxedo from college. So I think that I've always related with the problems that our patients have to a certain extent. And, when I've been most vulnerable, which is when I was working the hardest with the least amount of sleep, I related with it the most. And yes, exercise for me has always been my tool. More recently, exercise, some strength training I think is important compared with cardio. I don't do enough of either, but I definitely do some, and that helps. Meditation helps me a bit. I do that every night before I go to sleep. I use an app for it. It's probably not the best way to do meditation, but
if it keeps you doing it regularly,
exactly.
It's the best way to do it.
Andrew, I couldn't agree with you more. It's one of those things where I look forward to it every night. And, sometimes my wife falls asleep and I come to bed a little later and I whisper, I'm like, are you okay if I turn the app on? So, and she does the same to me because I think we both value it. And I think that's been very helpful. And I didn't have that tool probably when I needed it most, but I have it now and it's very helpful.
I really appreciate you sharing those tools. A number of people, I'm guessing out there, might want to become neurosurgeons. I really believe that in hearing today's conversation that you will spark an interest in medicine and or neurosurgery.
I hope so.
Well, certainly you need to be a physician before you can become a neurosurgeon. So, and neurosurgery in some cases, and that would be beautiful. And I predict that will happen, as a consequence of what you've shared today. I really appreciate your mentioning of the emphasis and appreciation on quality time. I very much see this as quality time. I know that our listeners will as well. Really want to thank you for taking time out of your not just immensely busy, but very important schedule, because again, the work that you're doing is really out there on that cutting, I don't want to say bleeding edge, because in this context, it's not going to sound right, but on that extreme cutting edge of what we understand about how the human brain works and how it can be repaired. You're doing marvelous work. We will point people to various places they can find you online, and should they need the help of your clinic, to your clinic and your laboratory as well. So on behalf of everybody and myself as well, thank you so very much.
I'm honored. Thank you so much for having me.
Thank you for joining me today for my discussion with Dr. Casey Halpern about the use of deep brain stimulation and novel technologies for the treatment of eating disorders and movement disorders of various kinds. For those of you that are interested in learning more about Dr. Halpern's research, please see the links in our show note captions that include links to his laboratory website and to his clinic, as well as various research publications that are available in complete form as downloadable PDFs. If you're learning from and or enjoying this podcast, please subscribe to our YouTube channel. That's a terrific zero-cost way to support us. In addition, please subscribe to the podcast on both Spotify and Apple. And on both Spotify and Apple, you can leave us up to a 5-star review. If you have questions for us or comments or feedback of any kind, please put that in the comment section on YouTube. We do read all the comments. Please also check out the sponsors mentioned at the beginning of today's episode. That's the best way to support this podcast. Not so much today, but in many previous episodes of the Huberman Lab podcast, we talk about supplements. While supplements aren't necessary for everybody, many people derive tremendous benefit from them for things like enhancing sleep and focus and hormone optimization. The Huberman Lab podcast has partnered with Momentous Supplements. If you'd like to see the supplements that the Huberman Lab podcast has partnered with Momentous on, you can go to Live Momentous, spelled O-U-S, so livemomentous.com/Huberman, and there you'll see a number of the supplements that we talk about regularly on the podcast. I should just mention that catalog of supplements is constantly being updated. If you haven't already signed up for the Neural Network newsletter, this is a monthly Huberman Lab podcast newsletter in which you get some brief show note summaries, as well as a lot of actionable tools in summary form. Many people find these very useful for distilling out the vast amount of information that we cover on the podcast. So for instance, if you go to hubermanlab.com, you can click on the menu, click to Neural Network Newsletter or simply Newsletter, and you can sign up. Just give us your email. We do not share your email with anybody. And again, it's completely zero cost. We also have examples of previous newsletters that you can download immediately without having to sign up for anything and decide whether or not you want to sign up. Again, that's the Neural Network Newsletter at hubermanlab.com. If you're not already following us on social media, we are Huberman Lab on Instagram, on Twitter, on Facebook, and on LinkedIn. And especially on Instagram and on Twitter, I cover many of the tools that are discussed on the Huberman Lab podcast, but also a lot of science and science-based tools not covered on the Huberman Lab podcast. Again, it's Huberman Lab on all platforms. Once again, thank you for joining me today for my discussion with Dr. Casey Halpern. I hope you learned as much as I did. And as always, thank you for your interest in science. Huberman, and I'm a professor of neurobiology and ophthalmology at Stanford School of Medicine. Today, I have the pleasure of introducing Dr. Craig Heller as my guest on the Huberman Lab podcast. Dr. Heller is a professor of biology and neurosciences at Stanford. His laboratory works on a range of topics, including thermoregulation, Down syndrome, and circadian rhythms. Today, we talk about thermoregulation, how the body heats and cools itself and maintains what we call homeostasis, which is an equilibrium of processes that keeps our neurons healthy, our organs functioning well. And as Dr. Heller teaches us, thermoregulation can be leveraged in order to greatly increase our performance in athletics and mental performance as well. Learning to control your core body temperature is one of the most, if not the most powerful thing that you can do to optimize mental and physical performance, regardless of the environment that you're in. He also dispels many common myths about heating and cooling the body, including the idea that putting a cold pack on your head or neck is the optimal way to cool down quickly. And in fact, as Dr. Heller tells us, it actually can be counterproductive and lead to hyperthermia. It's a fascinating conversation from which I learned a tremendous amount of new information. And we didn't even get into the other incredibly interesting work that Dr. Heller does on Down syndrome and circadian rhythms and sleep. So we hope to have him back in the future to discuss those topics. As you'll soon see, Dr. Heller is a wealth of knowledge on all things human physiology, biology, and human performance. It's no surprise then that he's been chair of the biology department at Stanford for many years, as well as director of the human biology program. So if you're interested in human biology and how to improve your performance in any context or setting, athletic or otherwise, I think you'll very much enjoy today's conversation. Before we begin, I'd like to emphasize that this podcast is separate from my teaching and research roles at Stanford. It is, however, part of my desire and effort to bring zero cost to consumer information about science and science-related tools to the general public. In keeping with that theme, I'd like to thank the sponsors of today's podcast. Our first sponsor is Roka. Roka makes sunglasses and eyeglasses that are of the absolute highest quality. I've spent a lifetime working on the visual system, and I can tell you that the visual system has to go through a lot of work in order to maintain clarity of what you see when there are shadows, when you go into different types of indoor lighting, and so on. And a lot of glasses don't work well because you put them on and then you're in bright light and you can see fine, but then you move into a shadow and then you have to take them off and they don't adjust or they don't adjust quickly enough. With Roka, their eyeglasses and sunglasses are designed with the visual system biology in mind, so you always see things with perfect clarity. The glasses are also terrific because they're very lightweight and they won't slip off your face if you're exercising, if you're running or biking. In fact, they were designed for the purpose of being able to be worn while you're engaging in those sorts of activities or simply working at your desk. I happen to wear readers at night when I drive or when I work, and I love their sunglasses because I can wear them anywhere, and also the aesthetics of their sunglasses and eyeglasses are terrific. Unlike a lot of other performance glasses that frankly make people look like cyborgs, the aesthetics on Rokas are really terrific. You could wear them anywhere you'd like to go. If you'd like to try Roka glasses, you can go to roka.com, that's ROKA.com, and enter the code Huberman to save 20% off your first order. That's Roka, ROKA.com, enter the code Huberman at checkout. Today's podcast is also brought to us by Inside Tracker. Inside Tracker is a personalized nutrition platform that analyzes data from your blood and DNA to help you better understand your body and help you reach your health goals. I'm a big believer in getting regular blood work done. And now with the advent of modern DNA tests, you can also analyze your DNA to see what you ought to be doing for your immediate and long-term health. We hear a lot these days about optimization, optimizing hormones, optimizing your metabolism, optimizing this, optimizing that. But unless you know the measurements of metabolic factors, hormones, and other things that are in your blood and DNA, you don't know what to optimize. With Inside Tracker, it makes all of that very easy. They can come to your house to take the blood and DNA test, or you can go to a nearby clinic. They send you the information, and you take those results, and unlike a lot of laboratories doing blood work out there and DNA tests, they have a simple platform, a dashboard that walks you through your results and helps you identify what sorts of nutritional or behavioral or other types of practices you might want to incorporate into your life in order to positively impact your immediate and long-term health. It's a very easy system to use, and you will gain a ton of information simply by doing that test, whether or not you end up making changes to what you're doing or not. If you'd like to try Inside Tracker, you can go to insidetracker.com/Huberman to get 25% off any of Inside Tracker's plans. Just use the code Huberman at checkout. Today's episode is also brought to us by Athletic Greens. Athletic Greens is an all-in-one vitamin, mineral, probiotic drink. I've been using Athletic Greens since 2012, so I'm delighted that they're sponsoring the podcast. The reason I started using Athletic Greens and the reason I still take Athletic Greens once or twice a day is because it covers all of my nutritional bases. In fact, if people ask me, and I often am asked, what supplement should I take? I always recommend Athletic Greens. And in fact, if you were to take just one supplement, I recommend Athletic Greens for the simple reason that the vitamins, minerals, and probiotics and adaptogens cover all your nutritional bases. And the probiotics optimize gut-brain health, which we now know is essential for mood, for immune system function, for metabolic function. It's just got so many great things in there. I really do feel better when I'm drinking my Athletic Greens. I mix mine up with some water, a little bit of lemon juice, and as I mentioned before, I'll drink it once or twice a day. If I travel, I might even drink it a third time just because of the additional stress on my mind and body. If you'd like to try Athletic Greens, you can go to athleticgreens.com/Huberman to claim a special offer. They'll give you 5 free travel packs. So these are little travel packs that make it really easy to mix up Athletic Greens if you're on the plane or in the car. And they'll give you a year's supply of vitamin D3K2. There's now ample evidence that vitamin D3K2 is supportive of the immune system and a bunch of other biological functions, and K2 has been shown to be important for cardiovascular health. So again, if you go to athleticgreens.com/Huberman, you'll get the Athletic Greens, the 5 free travel packs, and the year's supply of vitamin D3K2. And now for my discussion with Dr. Craig Heller. Great to have you here.
It's good to be here.
It's been a long time coming. I know that I and many people have a lot of questions about the use of cold. So one of the things that's happened in recent years is that for many reasons, people have become interested in things like taking cold showers and taking ice baths for many different purposes. Mm-hmm. You know, sometimes this is introduced as just a general health tonic, but other times people get specific about how it can improve resilience or it can improve one's metabolism. Could you just tell me a little bit about what happens when I get into a cold shower or an ice bath? What are some of the basic responses at the level of metabolism? Obviously, psychologically, we don't know exactly. It'll vary from person to person. But what happens when I submerge myself into an ice bath if I've never done it before?
Well, first of all, you get a tremendous shock. And what that's going to translate into is a bit of a shot of adrenaline. And I think this is really the so-called benefit, but I wouldn't call it a benefit, of the cryo chambers. You go into a cryo chamber and it's a shock. So you get a shot of adrenaline. So sure, you're going to feel different when you come out. You've had a shot of adrenaline, but it doesn't necessarily translate into any benefit in terms of your physiology or performance and so forth. Now, if you take a cold bath or a cold shower, a couple things are happening. One is you're going to stimulate vasoconstriction. So if anything, it's going to make it a little bit more difficult for your body to get rid of heat because you're shutting off your avenues of heat loss. If you're in a true cold bath, the overall surface area of your body is so great that it doesn't matter if you vasoconstricted, you're still going to lose heat.
Okay, so vasoconstriction, the constriction of, is it capillaries, vessels, and arteries all constrict, or just one or two?
Well, this is an area of controversy. In general, when people talk of vasoconstriction, they talk of the overall skin surface, and that is not true. The primary sites of heat loss, which we're going to get into, are the palms of your hands, the soles of your feet, and the upper part of your face. And the reason these are avenues for heat loss is they're underlain by special blood vessels. And these blood vessels are able to shunt the blood from the arteries, which are coming from the heart, directly to the veins, which are returning to the heart, and bypassing the capillaries, which are the nutritive vessels, but high resistance. So you can tell when you shake someone's hand what his or her thermal status is. The hand's hot or it's cold.
Do you think that's
Sometimes it's
part of the reason why humans evolved this practice of shaking hands, assessing each other's level of anxiety? We all know that a limp handshake is pretty indicative of something, and a firm handshake is indicative of something, as is the crushing handshake for that matter. Right.
Yeah, I really don't know what the evolutionary origin of handshaking is, other than to get your hand away from your weapon, perhaps.
Right. A couple of questions before we get into these specialized vascular compartments on the soles, the palms and the upper face. You mentioned whole body immersion, like into an ice bath or very cold water up to the neck versus a cold shower. Is there something fundamentally different about those two besides the fact that they both provide this release of adrenaline? Is there anything that's really important to understand about the difference in the physiological response evoked by cold shower versus immersion in cold?
Well, there are differences that are more physical than anything else. So if you are in a cold bath and you're still, you develop a boundary layer. If you're in a shower, you can't develop a boundary layer.
Could you explain what a boundary layer is?
Yes. It's best to explain it in terms of a hot bath, because everybody's experienced that. You get into a hot bath and, oh my God, it's really hot, almost painful. And then you sit down and eventually it doesn't feel so hot anymore, because the still water, which is close to your skin, is coming into equilibrium with your skin. So it's like having a blanket on you or an insulator on you. And then if you move around, you disturb that still water layer, you feel the hot temperature again.
I see. So if I were to get into a cold ice bath or very cold body of water of some kind and stay still, I'd likely feel warmer, at least until I start.
You're not going to be losing as much heat.
I see.
Right.
And then when
if
I move,
if you flail around, then you're going to lose more heat.
Got it.
Yeah. But I think getting back to your original question about benefits, you have to keep in mind whether you're talking about aerobic activity or anaerobic activity, if you're referring to performance and exercise and so forth. So if you're doing aerobic activity that you can sustain for a long time, your production of heat is rising gradually and is being distributed throughout your body. So eventually your body temperature is going to come up to a level that's going to impair your performance. So the benefit of a cold bath or a cold shower before aerobic activity is that you increase the capacity of your body mass to absorb that excess heat.
I see. So could you say that in a rough sense that a protocol that one might use if they're going to head out for a long run, even on a reasonably warm day, not super hot, or maybe it is super hot, would be to take a cool shower before they go run? Would that be beneficial?
Sure. It'll take them longer to get to the sweat point and to heat up.
And what will that translate to in terms of a performance benefit?
Could increase your speed, or it depends on how you use that benefit. Some people are pacers. They will go at the same pace and then they will go farther. Or some people are, pacers and regulators. And pacers or forcers. They will take that advantage and use it up as fast as they can. So they will go faster, but not necessarily farther.
I see. As far as I know, not many athletes, at least not the ones that I know, are getting into cool bodies of water, taking cold showers before they head out to train. But it sounds like there could be a real performance benefit there.
It could be a benefit. I know we're going to talk about our technology for cooling, but at one point, I don't know if they're using it now, but our cross-country team, when they would go to compete in a very hot place, they would do their warm-up exercises, their stretching. Then they would extract heat before the beginning of the race. So I like to think of it as you have greater scope for heat absorption.
Interesting. About how long would one need to take one of these showers or cold immersions before heading out for a run? Roughly speaking, we don't have to get into details because everyone's performance level and regimen is going to be different. Where they live is going to be different, et cetera.
Right. It's not as long as you think. It's minutes.
Couple minutes.
Yeah, because what's going to happen is as your core temperature goes down, you will eventually shut off your heat loss, and that keeps it from going below normal. So if you've warmed up and your temperature has risen by 0.5 degree, let's say, it doesn't take more than a few minutes to extract that heat if you're vasodilated.
Interesting. And what about for the anaerobic athlete, the strength athlete?
Right. For the anaerobic athlete, and let's say they're doing several sets, and how many reps, whatever they're doing. Their core temperature is not going to rise that fast because it's only certain muscles which are being used. But the temperature of those muscles will go up.
So it's a local effect.
It's a local effect, right?
Okay. So let's for sake of today, maybe for this discussion, if we assume that the basic workout, even though people do variation on this, is 5 sets of 5 or 10 sets of 10. So for those listening, it would be 5 sets of 5 repetitions, or 10 sets of 10 repetitions, 10 by 10, 5 by 5. Uh-huh. Yeah. So if somebody, let's say, is doing a large body compound movement like barbell squats, where there are a lot of large body movements, hip hinging, et cetera. But for instance, the biceps are not, they're involved, but more or less indirectly.
Right.
So the effect is going to be to heat up the quadriceps, heat up the hamstrings, heat up the glutes, this kind of thing.
Right.
I see.
And then during rest, that heat will leave the muscle, but it's not fast. And certainly the heat can't leave the muscle very fast while you're working out, because when the muscle contracts, it squeezes the blood vessels. And the only way heat gets out of a muscle is in the blood. And your muscle metabolism can go up 50 or 60 fold during anaerobic activity. That means the heat production in the muscle goes up 50 or 60 fold. The blood flow to that muscle cannot go up 50 or 60 fold. So you literally have the capacity to cook your muscles.
Mm-hmm. So this is probably an appropriate time to just mention briefly what the underlying mechanism of this is. Could you just, we will return to the specifics of what one can do to mitigate this heating up. But could you just explain the relationship between energy production, ATP, and pyruvate kinase and the role of heat there?
Sure. We don't get something for nothing. So like a steam engine, most of the energy in our food is lost as heat. So we are roughly about 20% efficient. So of the energy that we take in our food, about 20% of that can go into doing work, and the rest of it is lost as heat. Now, we're mammals. We use that heat to keep our body temperature considerably above the environment. But if you raise body temperature a few degrees higher, you're in trouble. That's hyperthermia. So individual muscles can reach hyperthermic limits before you might experience it in the whole body. So to keep you from damaging your muscle by hyperthermia, we have fail-safe mechanisms. And one of those fail-safe mechanisms is an enzyme which is critical for getting fuel, in other words, the results of metabolism of glucose, getting that fuel into the mitochondria, which is making our major coinage of energy exchange, ATP. Okay? So that particular enzyme is temperature sensitive. So when the muscle temperature gets above 39 or 39.5, it shuts off. And that essentially shuts off the fuel supply to the mitochondria. That's when you cannot do one more rep.
So failure, could we say that
failure.
One component of muscular failure is overheating of the muscle locally?
Right.
There are probably other things too.
Well, if you lack oxygen, but our oxygen delivery is pretty good to the muscle. If you run out of glucose, that's going to impair you. But the most immediate impairment of muscle activity, muscle fatigue, in other words, is the rise in temperature of the muscle.
Interesting. I want to talk about how that muscle fails locally, but I have this burning question in my mind that I cannot seem to answer for myself. I'm hoping you can answer it for me. So let's say I'm doing 5 sets of 5 with squats. Mm-hmm. I hit muscular failure at a given weight. Mm-hmm. And according to what I now know, it's my quadriceps and the muscles associated with the squat that have failed because of this heat triggering, this mechanism triggered by heat that shuts off the muscle. But my biceps are nice and cool. Yeah. You're telling me they're not doing too much work. It's only indirect work. Mm-hmm. So why is it that I can't set the bar down in the squat rack walk over and do barbell curls with the same intensity that I could if I were to do those barbell curls fresh, not having done anything prior?
Well, you will still have a fatigue curve with your upper body. Okay. And that will be influenced by any rise in temperature that has been generated by your lower body exercise.
So temperature in both cases is the limiting factor.
It's one limiting factor. It's one limiting factor.
I find that amazing. I find that amazing because I always thought naively that the reason muscles fail is because we, quote, don't have the strength to do another repetition, or it's that you lack glycogen or some ability to access that glycogen. But of course we still have glycogen. It's naive for me to think that, because if I wait 3 minutes and go back, I can do those repetitions again. So the glycogen wasn't restored in that 3 minutes.
Right.
Obviously it was there.
Right.
So I realize there might be other mechanisms involved. Sounds like heat is, if not the dominant mechanism that prevents more work, it's one of them.
It's one of them. And it's a quick one. It's a fast one. So it can happen with, let's say you are a really experienced weightlifter. Okay. You may be doing very, very high weights with sets of 5 or 6.
Yeah, to be clear for the audience, I'm not doing very high weights for the sets of 5. I'm not particularly strong. I'm not super weak, but I'm not particularly strong. But Craig's referring in the general sense to you. So why is it that if I finish a set of squats, I can't simply cool off my quadriceps by throwing a nice cool towel on my quadriceps? Why is that not the best way to go about it?
Because your body surface is a very good insulator. Okay, we think we don't have fur and therefore we're not insulated, but the skin, the fascia, the muscles underneath that they're all very good insulators. And that's why I said earlier that the way the heat gets out of the muscle is in the blood.
So I want to step through a couple other portals by which one might think that heating and cooling would be ideal, and then get back to these specialized surfaces on the hands, the feet, and the face.
Yeah.
So if throwing a cold towel or even ice cold towel on my quadriceps isn't going to work, or standing in front of the fan because I'm insulated from that cool, I can't cool off my blood fast enough. What about drinking 16 ounces of ice water?
Sure, you can do that, but you can calculate how much heat that can absorb. Okay? And you can't continue drinking liters of ice water. You're going to dilute your blood and have other problems. Right. But yes, it'll help. Sure, it will help. But it doesn't have the full capacity you will need.
What about an ice pack to the back of my neck or to my head, or squeezing the cold sponge over the head? I'm deliberately moving through these options because these are the ones that we see most often. We were actually just watching the Olympic track and field trials last night up in Oregon. I'm a huge track and field fan, and there were a lot of sponges on the backs of necks before and between and after events, and how good is that, or how poor is that as a strategy? Since now we know that being overheated locally and systemically throughout the body is a serious limiting factor on performance.
Well, you have to understand something about our thermoregulatory system. We have a thermostat, just like you have a thermostat in your house, and that thermostat is in the brain. Okay?
Do we know the specific site?
Yes. It's called the preoptic anterior hypothalamus. It does many things in terms of physiological regulation, but it serves as a thermostat. Now, that thermostat has to have information. It has to have input. Where does that input come from? It comes from our overall body surface, where we sense temperature. Okay? So one of the things that can happen when you're overheated is that you can send in a cold stimulus to your thermostat. And that's sort of like wanting to cool your house by putting a wet washcloth over your thermostat. It's doing the wrong thing. So we've actually had experiences where we've had people exercising, getting overheated, and then cooling the body surface. And they say, it feels great. This is fantastic. And their core temperature is going up.
Well, I think this is such an important point. First of all, I was weaned in a laboratory where there were always battles over the temperature in the lab. So people were always putting ice packs on thermostats or putting fans towards thermostats and trying to play this game. Good to know we were all being foolish, even though we were neurobiologists. putting a cold towel over my torso or putting ice on the back of my upper back, you're saying could actually heat up my core.
It'll at least decrease your heat loss, your rate of heat loss. You're going to raise the issue a little later, I know, and that is our natural portals for heat loss. So you can think of the natural portals for heat loss as our air conditioners. Okay, the thermostat's in the brain, and the information from the to the thermostat is coming from the overall body surface. So what can happen if you, let's say, cool the torso with an ice vest, you can actually cause vasoconstriction of your portals, your heat loss portals. So that's what impairs the rate at which you're losing heat. It feels good. Now, back to the head. That's really interesting. The major blood flow to the brain comes up 4 arteries through the neck. There's the carotid arteries and there's the vertebral arteries. So when you put a cold towel around the neck, you're going to be putting a cold stimulus into the brain. Well, that's great for protecting the brain. You want to protect the brain, but it's also going to make you feel cooler than you are. So you will think you're ready to go again quickly when you've just essentially cooled the thermostat.
This is an important point. And there's a lot of interest nowadays in people doing marathons, and there are even some people do these ultra running, which I guess is everything longer than a marathon, and go last man standing, last woman standing kind of things. So you're saying that if somebody's hyperthermic, they could trick themselves into subjectively thinking that they are cooling off by putting a cool towel, and that they can go further, but their brain could cook.
Well, if they stop the cooling, then that hot blood from the body core is going to go to the brain.
Interesting. Well, it's a bit of a tangent, but many people report after long bouts of exercise, or even just very intense bouts of exercise, feeling a kind of brain fog or mental fatigue. I assumed that was due to lowered brain oxygenation post-exercise, but is it possible that there are some post-exercise effects on heating and cooling of the brain that might impact cognition, or I should say negatively impact cognition?
It's certainly possible because we know that a rise in temperature decreases cognitive capacity. I mean, you can experience that yourself. You can get on a treadmill, and follow your temperature and then just do a simple activity like adding and subtracting. You get to about 39 degrees, you can't do that anymore. You can't just calculate how long you've been on the treadmill.
So the phrase "cool, calm, and collected" is
cool, calm, and collected.
That's the goal in all pursuits.
That's right.
So I want to talk about these portals, because you've mentioned them a few times. Before I ask about what the portals are exactly and how they work and how they can be leveraged for performance, there's a question that my neurobiologist self can't resist but ask. We have this thermostat in the preoptic area of the hypothalamus, which is interesting to me. The medial preoptic area is also one that's known to be sexually dimorphic, depending on testosterone exposure early in life, et cetera. Although people should just note that it's not actually testosterone that creates these sexual dimorphisms, these differences. It's actually testosterone converted into estrogen. It's actually estrogen is the effector, which is fascinating. Nonetheless, we've got this area that acts as a thermostat, and you said it's collecting information from the whole body. Does that mean that there are pathways, as the neuroscientists like you and I refer to them as these afferent or input pathways from the body to the preoptic area? Is there a map of our body in the preoptic area? Because I have to imagine that you can't have the information just coming from the left shoulder or just from the right toe. It sounds like you need probably a pretty crude map, but that you need a complete map of the body surface there.
Well, you don't need a complete map in the hypothalamus. I mean, that thermal afferent information that you mentioned, it also goes to the somatosensory cortex. So you know if an ice cube has touched you on the back. But that doesn't necessarily translate into a change in, let's say, you're shivering or sweating. So the information that's going to the hypothalamus is more integrated. representation of body temperature.
So it's sort of an average of what's happening
It's an
across
average,
the body.
right.
So if I were to, let's say I get hot on a hot day, and popsicles when we were in summer camp.
Yeah.
I went to a sports camp near here actually, and we'd run around like crazy, and then we get into the shade if we could, but we were, popsicles. It was all
Brain
about
freeze.
popsicles. Or the kids were putting ice cubes down each other's, shirts or something. But that's an average because other parts of the body aren't exposed. The mouth is exposed to the ice in the popsicle case, or the cold cubes, or in the hands. As you said, it feels really good.
It feels good, yeah.
But it sounds like it feels deceptively good because in reality, it could still be quite warm internally.
Absolutely. Yeah.
Interesting.
Yeah. You can feel great and have a dangerously hyperthermic temperature. But I should say that when you get into the danger zone, things get bad fast.
What are some of the symptoms that people could be on the lookout for hyperthermia?
Essentially, it's almost ironic that if individuals are transitioning into heat stroke, they actually vasoconstrict and they stop sweating. And that's a pathological situation. I couldn't begin to explain it. But essentially, you are just feeling exhausted. You're feeling miserable. The heart rate is very high. Your heart rate goes up as your core temperature goes up, called cardiac drift. So you just feel rotten. But that's why, since it's not it's not a danger signal that you can translate immediately into, nope, I'm going into heat stroke. That's why people can overcome their bad feeling with motivation to continue going, to work harder. So there have been a number of high-profile athletic deaths due to heat stroke that were during practice. Not in competition when people, are really trying to do it, but in practice, which shows they were just motivated to push.
So let's talk about these magnificent portals that not just humans, but other mammals are equipped with. So if putting cold on the neck or on the head or on the torso is not optimal, what is optimal? And maybe walk us through a theory as to why we would have these portals located where they are. And then we can talk about how one might leverage them for performance.
Okay. Where the portals are in the glabrous skin. Big word. Okay. Glabrous just means no hair. So it's the hairless skin. You say, well, most of my body is without hair. No, most of your body has hair follicles. We are mammals. Mammals have fur. We've lost the fur, but we still have that hairy skin phenotype all over our body, except for those skin surfaces where our mammal relatives didn't have fur. So the pads of the feet, and for the primates, upper part of the face. For rabbits, no portions of the ears, the inner surface of the ears.
I never thought about that.
For bears, the tongue. Bears have big tongues, huge tongues.
I didn't know that either. I haven't been that close to a bear yet.
I haven't had a licking match with a bear.
Not yet. No.
Okay. So anyway, our mammalian relatives can't lose heat over their overall body surface. So probably very early on in mammalian evolution, they evolved these special blood vessels in the limited surface areas that don't have fur. And as I said, what these blood vessels are shunts between the arteries and the veins. Arteries and veins are both low resistance vessels, so you can have high flow rate. Capillaries, which normally are between arteries and veins, are high resistance because they're very tiny. Okay.
Is it fair to say that what I was taught is that blood flows from arteries, then to capillaries, and then to veins, and then back to the heart? So it's sort of like from the heart through arteries, then through these little capillaries, which are like little estuaries and streams, and then to the veins, back to the heart. Is that generally true?
Yeah, absolutely.
Okay. So what I learned in basic physiology is still,
it's still.
I wouldn't get an F in your class. Anyway.
No.
Okay. Maybe a D or a C, but not an F.
So that's excellent.
Okay. And so you're saying that in this glabrous, or beneath the glabrous skin,
there are these shunts.
and those go directly from arteries to veins. So you
Right.
skip the capillaries.
Yeah.
I see. And is it actually, as long as I say that in the skin, when I feel the pads of my hands, how deep to the surface do these vessels reside?
Well, they're below the obviously
Sure.
the epidermis. So if you are warm and you look at your palms of your hands, they are fairly red. The backs of your hands aren't. You don't have these vessels in the backs of your hands. Now, if you take a glass, like a water tumbler, right, and you grab it, you can see if you squeeze a little bit, the hand goes white. That's because you've shut off that blood flow.
Oh, interesting. I'm going to do that little home
So
experiment.
if you're bicycling on a hot day, you don't want to be grabbing your handlebars all the time. You want to periodically.
Well, this is important. I know you're privy to some really amazing results that we're going to talk about, but I actually heard you say this during this lecture recently that Stanford held about human performance that we're both part of. And you mentioned this, that if you're cycling and you're working hard and you want to be able to do more work, we now know why you want to remain cool in order to continue to do work. And if you get too warm, that's bad. That gripping the handlebars too tightly will actually limit your performance.
Right.
And that's probably also true on the Peloton or any other kind of
Right.
device, or the skier or anything
Right.
like that.
Right.
So loosen the grip, or if you safely can, you
Right.
want to actually expose your hands
Right.
to the world. Now, what about for people wearing gloves? What about the to me, that just seems crazy based on everything you're telling me.
Well, gloves definitely impede heat loss from the hands, just as socks impede heat loss from the feet. Okay. So if you want to maximize your heat loss, you want to have as thin a protectors as possible on your hands. And of course, the feet are more problematical because you have to be using them in certain ways.
Some people run barefoot.
Yeah. Well,
But,
yeah.
that's become somewhat popular. It seems like it kind of came and went. They had those toe shoes things, but they looked so ridiculous that I think most people just were willing to take the performance hindrance of regular shoes.
Actually, we had a track coach here at Stanford who, for a while, was famous for introducing training without shoes, running.
Interesting.
And he thought it was because it changed the posture of the runner. And I think it was just due to the fact that he was increasing the capacity of his runners to lose heat.
Interesting. Yeah. So heating up at the level of the hands obviously is going to hinder performance. So if I can, how about with running? I noticed I ran cross country briefly in high school and not particularly well at that, but that we were told to run as if we were holding, crackers in our fingers or something, like very lightly, and to keep hands kind of loose. So running like this would actually be more beneficial performance than, or gripping a phone, which is probably what most people are doing nowadays. Right. Interesting. And
I'll tell you an experience I had once. I was in Alaska in the winter and I went out running and I absentmindedly forgot gloves. And I realized this after a short period running because the backs of my hands were aching from the cold. The palms of my hands were sweating and were hot.
Oh, amazing. Amazing. So these compartments are a real thing. And you mentioned the upper half of the face.
The upper part, that's where our primate ancestors don't have fur.
And the bottoms of our feet. So let's just take a moment and talk about some of the more amazing results that have been associated with proper cooling of these glabrous skin surfaces.
Let me introduce one more thing,
Sure.
because you asked earlier about the pouring of water on the head. Okay? One of the things which is not appreciated fully is that the blood which is perfusing these special blood vessels in the face above the beard line, that's the non-hairy skin, that blood then returns in the venous supply to the heart, but it actually does it in a very strange way. It actually goes through what are called, I'm blocking on the name now.
Take your time.
These are blood vessels that go through the skull. Okay. And that's why the scalp bleeds a lot if you cut the scalp. And these blood vessels, which are called, I want to say emergent, but it's not emergent. It's a word that means leaving. And these blood vessels were primarily thought to be ways that blood is leaving the brain. But when you're overheated, the direction of flow in those blood vessels reverses. So the cool blood that's coming from your facial region goes into that circulation and actually is a cooling source for the brain. So you can cool the brain, you can have a cooling effect on the brain by pouring water on your head.
Interesting. So that practice, which we, at least for me, I most commonly associate with combat sports, where the fighter goes to their corner. They usually sit down on a stool, unless they're trying to do some mental warfare from the corner, in which case they don't even take a seat, and their corner crew will squeeze a sponge full of cold water over them, or that you're saying is somewhat effective in cooling the brain.
Yeah, it's one of the natural mechanisms for cooling the brain.
I want to return to this at some point as well, but is there any known benefit to cooling the brain in terms of offsetting physical damage, offsetting the negative effects of concussion? Because one of the reasons why fighters will often get a cold on the back, cold item on the back of the neck or on the head, is not just to cool them down, but the theory is that it might offset some of the damage of neurons.
I just can't comment on that. I'm aware of those ideas, but they're controversial. One of the things that you want to do for injury to the brain is to decrease swelling. And one of the ways that you decrease swelling in many parts of the body is to cool. It decreases inflammation. It decreases the blood flow. So, I think it's a really interesting topic, and it's something that should be investigated. It's kind of hard to investigate.
Yeah. Interesting. Okay. So I hear these stories and I've seen the data, so I believe the stories. Maybe tell us a story about an observation that your group has made with respect to anaerobic exercise and this proper cooling of these glabrous surfaces.
Yeah.
And we can talk about the technology.
Yeah.
Maybe give us the dips example first.
Okay.
Dips, of course, I think most people are familiar with dips. You're supposed to, I guess,
raise and lower your body.
Yeah, raise and
mass.
raise and lower your body mass, usually with your legs dangling down. Sometimes people are strong enough to attach a weight there, and it's essentially a compound upper body exercise.
Right.
One dip would not be particularly impressive for most people. 100 would be very impressive. 20 would be impressive for some, etc. What happens when a skilled athlete comes in and does dips for multiple sets? And then what happens when they cool properly using the glabrous skin surfaces?
This was a story that occurred early on in our investigations when we first made the discoveries that cooling has a benefit to increase your work volume, your capacity to do more reps. Okay. So the word got over, I think, to the 49ers camp. And one of their players, Greg Clark, who was a tight end at the time, he had been tight end at Stanford, he decided, or I don't know if he was asked or what, to come over and check it out. So Greg came over and we said, Greg, what are you good at? What activity do you like to do? He said, dips. I can do a lot of dips. I can do 40 dips in a first set, and I can probably do 5 sets. That's a usual workout for me. And we said, okay. So he came over to the gym one day, and that's exactly what he did. He did 40 dips the first set, and then maybe 25 and 15, and down from
Do you
there.
recall roughly what kind of rest periods he was taking between sets?
Yeah, we standardized the rest period to 3 minutes because that's what we had set on for cooling as the intervals.
That's a good long rest period.
It is.
Still a lot of dips. I got it.
Yeah, it's actually a longer rest period than many people would prefer during workouts. They want to make the most.
Not me. I prefer to take as much rest as I possibly can. Yeah.
So several days later, he came back, and his first set he did, I think, maybe 42, a little bit better. But now people were standing around watching, so there was a little impetus there to show off. So then his second set was, I don't remember the numbers, but very much above the second set on the control day. This was after we cooled. His
Okay, so he does.
Palmer
When is he
surface.
doing the cooling?
He's sitting down and putting his hands in the devices that we had built, which were cooling the palms of his hands.
For how long does that cooling take? Can he do it inside of a 3-minute rest period?
Yeah, that's what we were doing.
Yeah.
We standardized the
Okay.
the interval for resting or cooling to 3 minutes. Okay, but the point is, he got to his fifth set, and all of the sets were above what he had done on the previous day. And he said, I'm not tired. I can do another set. And then I can do another set. I can do another set. I can do another set. So from one day to 2 or 3 days later with cooling, he doubled the total work volume. He doubled the total number of dips.
By adding more sets and more repetitions to each
Right.
set.
Right. So then he kept coming back for 4 more weeks, twice a week. And by the end of that month, he was doing 300 dips.
Wow. So what
So
percentage?
he tripled.
He tripled
essentially
in-
tripled. And so here's a professional athlete at peak physical conditioning, and he triples
Amazing.
what he can do.
Amazing. And in terms of his ability to recover, was that explored or discussed at all? Because my understanding is that if we cause enough stress to a muscle during anaerobic training, we provide the stimulus for compensatory regrowth, et cetera.
Right.
But if we do more work, we essentially scale up the amount of recovery that's needed or the recovery time. I'm very curious about whether or not he needed longer to recover between these super performing workouts.
That's very interesting. That was a major discovery, which we didn't realize we were making at the time. There is this phenomenon you're referring to as delayed onset muscle soreness, DOMS. And this is due to those little micro tears and so forth that are happening as we extend our workout capacity, volume. Okay. So we've had this experience so many times that an athlete or anyone will come in to the lab and they will exceed what their previous goals were, their previous expectations. And I can always see the words coming out of their mouth. I'm going to be so sore tomorrow. They never are.
Interesting.
And we've actually demonstrated that with a naive group. We had a class, physical conditioning class, and we had half of them. The first days of the class, we had to establish their true capacity, what they could do. So these were pretty heavy workouts for these new recruits. And we gave half of them the benefit of cooling and the other half not. And then we had them record their subjective levels of delayed onset muscle soreness. And those that were cooled didn't have significant muscle soreness.
Amazing. And I know there are also published results, and we will provide links to some of these papers for people seeing similar effects, I should say similar performance enhancing effects using bench presses in the bench press or push-ups or other sorts of things. Maybe you could give us an example from the realm of endurance work or
Sure.
aerobic work, running, cycling, things of that sort.
Well, one of the problems with for us is that our equipment now is not really portable. I mean, it's portable in the sense you can carry it to the gym or to the football field,
But you're not going to run with
but you're not going to run with it, right?
or equip a bicycle with it. Although when are the cooling handles on bicycles coming?
Yeah,
Right.
that would be good. But one itinerant activity is golfing, and people have put it on their golf carts, and they're
Do
out.
people really heat up that much in golf?
They do.
Not to be disparaging of the golfers, but the way I conceptualize golf, it's like a swing and then a walk and then a cart ride and then a meal. I probably just offended all the golfers out there.
Well, one time we were doing work for the Department of Defense, and they wanted to check it out whether or not what we were doing was really worthwhile. So they sent out a team of special ops soldiers to be our subjects and test it out. They were here for a week, so that was a fun week.
Yeah, I do some work with those guys. They're hard driving guys. They also know how to have fun, but
Right.
they definitely have. If they have an off or a quit switch, it's buried deep within their nervous system. They don't like to hit that quit switch.
So the guy who wrote the final report, he gave an addendum to the report, and he said, Well, I'll tell you this. After I've gotten home, it's added that technology. They took the technology with them. They wanted to keep it.
That sounds about right.
I said, and using it, it has added 20 yards to every club in my bag, and that's no effing small deal.
So it's allowing people to hit the golf ball further.
Right.
Interesting. All right. So for the golf players out there, and that's the reward you get back from Craig for all my little knocks on golf. I don't have any knock on golf. I just don't think about it as a sport where heating up is a limiting factor. So since they're getting more out of their drive, what do you think's going on there?
Well, they can be heating up.
And they're wearing gloves, right?
They're wearing gloves on a hot day and so forth. But let me just tell you one more serious story about golfers, and that is individuals with multiple sclerosis are exceedingly temperature sensitive.
I didn't know that.
So they may still be mobile, but they have to stay in cool locations and not increase their exercise to any great extent. But we've had subjects that have, with multiple sclerosis, who have just essentially put the device on their golf cart and they're back out playing golf in the middle of the summer.
Oh, that's great.
Yeah.
That's great.
It doesn't.
Anything that allows people to have normal levels of livelihood and recreation is great. We always think about performance at these kind of like peak and elite levels and pushing harder. But yeah, anything that allows people to be mobile and functional is great. So what's your favorite example of endurance? And feel free to give us the extreme one, and then we'll talk about averages to be, make sure we're thorough about averages versus exceptions.
Right. We haven't done a lot in the field. I mean, outdoors. Most of our endurance has been in a hot room with treadmill work and so forth. So the very first experiment we had, I think, maybe 18 subjects just off the street. I mean, we just recruited people in the hallways, come on in and do this. And what we found is we could, for this group, with one trial with and without cooling, we could double their endurance walking on the treadmill, walking uphill on the treadmill in the heat, like maybe 40 degrees ambient temperature, 40 degrees centigrade.
So what does that experiment look like? You're having people walk on an incline. It's really warm. Some people are just going to hit the quit button and say, I've had enough, and get off the treadmill.
Right.
With proper cooling. When are they doing the cooling?
They're doing it continuously.
I see.
Because in the laboratory, we can suspend devices from the ceiling, for example. Now we do have prototype wearable devices. We did them in response to emails from Ebola workers a number of years ago in Sierra Leone. They said, we've read about your work with athletes. Can't you do something for us? I mean, we're in the personal protective gear and we can't be in the hot zone for more than 15 or 20 minutes. So that started us on the challenge of developing wearable systems that could go under the PPE. We've published that work now. But
that's great. And I'm guessing the military special operators that are out in the desert and other locations are probably excited about this technology.
Well, once they get it.
It's coming. It's coming. I think some people might wonder, if there are all these studies and there are these incredible results over the years, why haven't we heard more about it? And I will ask your opinion on that as well, but I'll just editorialize a little bit. Is that the best laboratory work and its practical applications oftentimes requires many studies. And oftentimes there isn't a portal, so to speak, to get that information out into the technology sector. So there is a company that's developing this technology for people to use and to purchase and use. You might as well just tell us now, what is the name of that company, and do they have a website? People are going to want to know where can they get this magical technology, and is there a poor man's version of it as well?
Well, the company is Arteria, Arteria, and the website is www.coolmit.com. So CoolMit is just COOLMITT, coolmit.com.
It's a great website. When I went there, it says that right now the technology is only available to professional sports teams and military. Is that true?
Well, where we stand now is the new version of the technology is sort of in beta test versions. We got it into the hands of people who had used the technology before. So there's NFL teams that are using. There's college teams, there's Olympics, there's the Navy SEALs, Major League Baseball, the NBA, the National Tennis Association. They have locations where now they are trying this out and reporting back. How's it working? How could you change it? How could you improve it?
Great.
And so forth. So that's where we are. But on the website, you can actually sign up for being one who will be able to get one when they are finally manufactured. They're now being made in fairly small lots because you want to change things as you realize how it can be improved.
Yeah, this is Stanford after all. You want to get the technology right. I like to joke that one of the reasons I like being at Stanford so much is that not only are my colleagues amazing and they're so forward thinking, but they're all perfectionists. And so the perfectionist mindset is it has to be perfect before it can go live, so to speak. Well, I think there will be a lot of interest. Let's talk about the technology in a little more detail for a moment. And then let's talk about whether or not cruder forms of that technology exist, either for sake of safety and or performance. So what is the cool mitt, as I understand, is it's a mitt, it's a glove. Yeah. You put your hand into, you hold on to a surface, and that surface cools your hand, and thereby through this specialized portal cools your core body temperature and all the muscles of the body. Subjectively, if I were to do this right now, would I think that it was ice cold, or would I think it was just cool?
Just cool.
I see.
Ice cold is too cold. So people always ask, well, why can't you just stick your hand in a bucket of ice water? It's too cold. What that does is that causes reflex vasoconstriction of the very portals that you're trying to maximize the heat loss from. So you stick your hand in cold water, when it comes out, it's cold.
You just sealed up all the heat in your body.
Yeah, right. So what I sort of recommended to someone at one point, they said, well, when I'm running, can't I just carry a frozen juice can and it will gradually melt? And I said, well, no, because that's going to decrease the heat loss from that hand. But if every couple minutes you switched hands, it might work.
Well, I have a feeling that there are people now doing that as well as trying this. So how long in the cool mitt at the proper temperature, how long are people putting their hands into the mitt?
Well, we once again had just standardized on 3 minutes. And part of the reason for that is that the rate of heat loss is an exponentially declining curve. Okay. And 3 minutes sort of gets the best part of the curve. So you can go longer and get more benefit, but the biggest bang for the buck is in the first 2-3 minutes.
Okay. You mentioned a number of impressive organizations, sports teams, and military that are using this. This is not something that I typically see on the sidelines of games, although to be honest, I haven't looked very carefully. I'm guessing that they are probably keeping the technology somewhat under wraps. Where and how are they doing this? Are they running back to the locker room? I mean, the military special operators are doing their thing, but in terms of the athletes, is it possible, hypothetically, that athletes are doing this somewhat incognito?
It's possible, but I really don't know. People have mentioned here at Stanford, they don't see the football team using it. Well, the football team here at Stanford is mostly playing in cold weather, cool weather. The night games are cool. Even day games are not very hot frequently here. But when they go to a hot place like Arizona or Utah, at least our coach, Shaw, says that they take it with them, and that's when they find the benefit. That's when they use it.
Interesting. So is there a poor man or woman's version of this? You mentioned the juice can passing back and forth. You mentioned cooling the hands. A number of people said to me after learning a little bit about this science and technology that they've experienced some big effects, positive effects of cooling by, and I confess I've done this, taking a package of frozen blueberries and just kind of passing it back and forth between my hands. Now talking to you, I realize I probably didn't do it long enough. I was only doing maybe 30 seconds passing it back and forth between my hands and then going back into sets. I did see a performance enhancing effect, absolutely. But I realized I probably wasn't optimizing the protocol. If you were going to give a crude protocol for, let's just say for the gym, because with running it's a little bit tricky, but what would that look like if people wanted to just play with this in some sort of fashion?
Well, would be experimental.
Sure.
And
none of that is very controlled.
Your idea of frozen peas is a good idea. And I think since there's been no actual study of that, you would have to be you working out what is the best for you. But one way to figure it out is that if after you hold the cold peas in one hand and you switch it to the other hand, if someone then comes and feels your hand, is it warm or cold? If it's cold, it means you've vasoconstricted. If it's warm, it means the hot blood is still going there. Okay, so we do that in the lab.
And the key is for it to not vasoconstrict.
Right.
Okay. So there's a test out there, folks. If you're going to try this in kind of crude fashion, at least until the cool mitt is available more broadly to the general public, you could want to assess whether or not your palms actually feel cool to the touch by somebody else.
Right.
And if it does, that means you've essentially shut down the portal. You're sealing in more heat, which is bad. What about putting this cold